Hello, hello. Welcome again to another day of review. I'm glad that you're here. And we shall begin because we have a lot to cover today, day 2 of review. I really like these stars and nice pictures for my power slides, so I thought I would share it with you. Did I share with you the saying? Yes, be like the flower. Use the rain to help you grow. Another good saying from an old person somewhere in the world. Okay, now to continue, yesterday we stopped at just an introduction of pediatrics here. I told you that when you are in an environment, you have to think like the leader of that environment. So emergency room doctors think differently from pediatric doctors, from OBGYN, from cardiologists, respiratory medicine. Even though they think differently, the priority should always be at the back of your mind of ABC. Airway, breathing, and circulation trumps all fields. Okay, so even in psychiatry, if you're really wondering, okay, I'm talking to a woman here who is, history of trying to injure herself or cut her arms, and she's really not responding well. She looks like she's a bit dizzy. Could it be that she's lost so much blood? Does it mean that when a patient cuts their wrist, they did not try and cut their, brachial artery or the, dive a dagger into their femoral arteries? So you want to think in broad terms. If a woman is in front of you and she's expecting again, and she's looking a little bit dizzy, you want to do those vital signs. It could be anything. And there are certain conditions that need the alert of a specialist. I mentioned yesterday, eye conditions. Anything off with your ABC, you want to first manage, and you can even tell the patient, let me start managing you. Let me start stabilizing your breathing with some oxygen. Let me put 2 large bore IV cannulas in your arms and just replenish some of the fluid that you have, okay, that you have lost. And then I will alert my consultant or the specialist team, and as they come, we can continue with a bit of history, okay? So for pediatrics, think like a pediatrician. These guys know their milestones and their vaccines. Lean on the side of caution. The worst type of regret is the unfortunate demise of a child in your hands, and you could have done something about it. Do not dismiss a mother's concern. She may think it's not serious, but it may be more serious than her report. My child looks a little bit yellow. I tried to wash them and put some lotion on them, but the yellow color is not coming out. Okay, can you bring your child in? You see the child, goodness, is almost looking like an orange. Yellow eyes, they are lethargic, they even have a rash. So you want to at least at some point say you want to see the child. And in the point of errors, and we touched on that yesterday briefly, yeah, when you or your teammate has made an error, sorry goes a long way. Don't make excuses. Never say we were too busy or we had to deal with emergencies. If you're walking into a station and a patient tells you you're late, say, I'm sorry, but I'm here now. Can I just find out what is going on with, can I find out what your concerns are? Never say I was busy with another patient. Do you think they care? Do you think they care that somebody else was dying and you're doing CPR? So don't bother with these things. Accept the blame and keep moving. If a patient is complaining about your colleague, you cannot side with the colleague because you do not know what has gone on. You cannot side with the patient either, but you have to be a wise judge. Listen to what the patient has to say. Say you will go and investigate with the nurse and see why she didn't, give the jab, why she didn't change the diaper, why she gave the baby cold food, why she exposed the baby and didn't cover the baby's head. Okay, those are the little complaints people deal with in pediatrics. So you want to first listen to the complaint, apologize, just say sorry. Okay, just say sorry, and then you can ask for time to investigate. Don't be a weak doctor who just runs. The patient is complaining, go tell the consultant. The student is complaining, go tell the consultant. No, there are some things you can handle at the level of an FY2. Show genuine concern. Show genuine concern. So there are some people who say sorry, but they don't mean it. Practice in front of a mirror how to make your face mean your words. Okay, it's actually an art. Now, I had to scramble through my brain yesterday because I was just sitting down, and I do like to talk to my parents about my teaching sessions, and I'm like, if I told there's one thing that people hate in if you're not a pediatrician, is milestones. So my dad said, why don't you make for them a mnemonic? So I said, okay, let me just try and think of something that at least will guide them as they're asking for milestones. Because if you're not in pediatrics, this stuff, all you need to know is your baby, sitting? Are they walking? Okay, are you happy? Let's go. Okay, but here's a nice little thing. It took me some time to come up with it, and then I found others online which I'll share with you. So just general milestones. You're thinking of the word milestone. Okay, mouth. Is a child vocalizing any words? Are they babbling? Are they smiling? So you're thinking about the mouth. Then the eyes. Trust me, I had to settle for this spelling of eyes. It's the Russian spelling. Okay. Can your child track you across the room? And of course, you're thinking of the age group. So you will not be asking for a brand new baby. Are they vocalizing or are they babbling or are they smiling? Okay. So the smiling of a newborn is mostly spontaneous. It's so funny when parents come in and say, he's smiling at me. No, he's actually just stretching his muscles. Okay. Can they track you across the room? Are they fixated on bright objects, bright, colorful things? Do they lift themselves up, lifting their head up or lifting to a sitting position? So you're thinking age group wise, okay? Ears, can they turn their head to sound? Right. So if a patient is coming in and saying that their child is not listening to them, are they a naughty child? Maybe their child is deaf. Okay, and usually you have connections between deafness and speech, so it's at least good that you can ask about the mouth and then the ears, then move on to sitting. Can they sit with support or independently? Do you have to prop them up with some pillows? This must be making you happy. Children really develop very fast. It's important to document these milestones, so when he's a little bit older, you can just show him all these pictures and videos. Okay, it would be nice if my parents did that for me. Anyways, let's stop regretting all these things. Anyways, sitting. Can they stand with assistance? Okay. Are they trying to walk? So you're thinking of the sitting, the support, independence, supine to prone, rolling, standing with assistance. Then you can always just throw in walking. Then touch. Transferring objects hand to hand. Picking things with a pincer grip. Do they feed themselves? And then the last O, okay? Here, one cube building, one word meaning. Do they understand no? Do they understand yes? Okay? Now, and then I have these ones in red. So my triggers for problems would be they're not weight bearing, they're not sitting, they're not speaking. They have any child who has an exaggerated muscle tone, posture, and movement you want to investigate. But this is a little bit of a guideline, especially if you don't have time to really dive into pediatrics to gather the information. Then the 2-year-olds, this one I got, I think, from EPO medicine. 2-year-olds, the rule of twos. They run on their 2 feet. They can climb 2 steps. They can draw at least 2 lines, 2 parallel lines, okay? They understand a 2-word sentence, stop that, okay? 2-step commands, come here, okay? Go away, sleep. Toilet training also starts at that age of 2 years old. So if I was making questions, goodness, look at all these questions I can make. That's why I said in pediatrics, you can have 1,000+ cases. Okay, a woman can come in and say, my child is really not toilet trained. They're still wetting the bed. Okay, what should I do? Bed alarm. Do you know how traumatic those things are? That's why we see some people in the hospital, they're full-blown doctor, but they're so scared of their alarms going off. Because their mother put for them a bed alarm to prevent enuresis, yeah? You want to think of different reasons why a child could be still wetting the bed. Especially, you want to find out, was there a dry spell? By the way, I've started already discussing the cases, so I hope you have your pens and papers ready. We're talking about toilet training and delayed developmental in toilet training. Okay, of course, girls develop a bit faster than boys, and the boys end up to catch up a little bit more. But a child 6 to 7 years old should be completely done. Okay, so first things first, don't think of abuse. Of course, it's one of the differentials, but first I would make sure, let's talk about their lifestyle, because there are different causes to a child wetting the bed. It could be lifestyle, it could be environmental. Okay, Mama Samantha, there you are, you've put the baby on the 3rd level of the double decker. She sleeps all the way at the top. She has to go down the ladder and then walk all the way downstairs or to the outhouse to pee in the middle of the night. Even me, I would reconsider twice. Okay, so you want to think of environment. You want to think of what time is she taking a lot of fluids before she goes to bed? Is she afraid of the dark? And then you want to fix these things. Put the baby on the lower level of the bunk bed. Put a small lamp for her or a small light. Okay, there are little plugs that you can plug into sockets so that at least she can trace her way to the bathroom. Okay, other things you may want to find out, could it be like an early sign of juvenile diabetes? So this child is just wetting the bed during the day. Are they thirsty? Are they running to the bathroom frequently? So these are things you want to think about. And then now changes, because regression is a very big thing. You know, is there any non-accidental injury in the home? Who's in the home? How is the environment at home? Is she afraid of anyone in particular? Does she have night terrors, screaming in the night? Is she afraid? Okay, and then afterwards you want to try and explain it to the mom. There are different reasons for enuresis, bedtime enuresis. Sometimes the child is just afraid. Let's fix that. Okay, it could be the environment. Let's fix that also. But you need to explain to her that the connection from the neural connection from the brain to the bladder has still not yet developed. So the bladder could be filling up and be at its capacity, but then by the time it sends the signal to the brain, wake up and sleep and pee, the accident has already happened. Another reason, the child could be just a heavy sleeper, just knocking out and, you know, being semi-conscious. They do not they're not sensitive sleepers. So that could be another reason. Okay, what does this mother need to do? Not a bed alarm and not medications. So let's try and control the lifestyle in a bit of training. Before she goes to bed, she needs to use the bathroom. Okay, sometimes limiting fluids is not that appropriate, especially in the pediatric population. But of course, you're not giving her a whole jug of water to go and drink before she goes to bed. Okay, caffeinated products, sodas, and all these things you may want to throw into your conversation. I've told you about the lights, and then talking to her, because who is the one being affected? Is it because you, Mama Samantha, don't like to wash the clothes and hang the mattress outside for the neighbors to see? It's not about you, Mama Samantha. It's about the child. This is embarrassing. Talk to her and explain to her some of the reasons that could be causing her to wet the bed. Find out if she's having any problems in school. Remember the circles that I taught you on day one. We first start with the child and then we move out. If we are concerned it might be an infection, which a UTI in a 6-year-old child, big question mark, okay, for abuse, yeah? You want to talk to the child, make sure she's not been psychologically affected. Tell her, you know, my dear, some of these processes take a little bit of time. Don't feel bad about it. Don't condemn yourself, okay? Make sure her brothers are not laughing at her when nobody's at home, you know, calling her different types of names. This toilet training really affects people's, you know, self-esteem. So the mom wants to really give the child time, okay? Secondary methods of what is it, desmopressin? No, you'd never want to offer that in the beginning. And you never want to offer a bed alarm to start with. Before a bed alarm, can the mother put an alarm for herself to wake up and go and wake the child up? Okay, so you can talk to the mothers about such things. Now, this one really made me really happy, because the thing is with medicine, if you learn it once, try and learn it in a way that you can memorize it. So if your mind is the type, some of you have been really gifted to just memorize things and at one go. But I'm the type of person who likes stories. I like to create pictures in my mind. So I was so happy when I saw this on epomedicine.com. It's a mnemonic for milestones, okay? A story mnemonic. So you're thinking about milestones from the age of 2 months all the way to 12 months. So it's the sleepy mnemonic. At 2 a.m., you lift your head up, turn your head towards the alarm, okay? Then you smile and you snooze, okay? Then 4 a.m., this time you're more determined, you lift your head, you lift your chest, you yawn, you're cooing, okay? And then now you laugh a little bit. Then you go back to sleep, of course. 6 a.m., you roll over and you reach for your cell phone. So the way they make this is just for you to associate it with something so common. And honestly, I now can remember my milestones better just from yesterday, which is important. The Plab is helping both of us, yeah? 9 a.m., you're pushing up, clapping your hands, you're doing a bit of exercises, you're 12 o'clock, you're walking to the kitchen, making yourself some food. So it's nice. 2 months, they lift their head and they smile. 4 months, they lift their head, they lift their chest, and then they laugh. So you're thinking about that, slowly waking up and applying it to your milestones. 6 months, they are rolling over. Of course, they're not reaching for the cell phone, yeah? They transfer objects. They can sit on the bedside. They can respond to their name, wake up Tommy, okay? 9 months, they can push up. They can clap. Their pincer grasps. They can try to stand. 12 months, they're walking. They can pour out a pincer grasp. They can pour out an object, okay? So like if you've given them some milk to drink, they just dump it out. They can finger food themselves. So this is the thing. If you have two ways, and that's why even when I tell you, when you're doing your history taking, learn different methods of history taking. So there's the Socrates. I've given you the old cut. There's the past, present, and the future. Just in case you try to start one car and it jams. Gosh, I've forgotten my old cut. I've forgotten Socrates. What else can I have to fall back on? I can fall back on the past, present, and the future. Milestones, the same thing. You have this one here, milestone, and now you have this one, the story mnemonic about waking up. Okay, now let's do a case. You are the FY2 in the pediatric clinic. Samantha Jones has come in because her child is having trouble walking. It depends the age of the child. I know I've talked about delayed walking in a different capacity, okay? But when they handed this out to us, I said, goodness, this can really evolve into so many different cases, okay? Is the child maybe less than 3 years old? There are differentials for that. Ages 3 to 10, there's differentials. Older than 10, and of course there are other cases that just affect everybody else. But you're in front of Samantha, of course, first start with your rapport. Hello, Samantha, my name is Dr. X. I'm one of the juniors in the pediatric clinic. You have to introduce yourself with your name and your title, okay? Because some of you look so young, they're wondering, where's the doctor? And you're like, I'm the doctor. Really? You just look like you came from high school. And some of us are a little bit, wizened up and we have a bit of white hair. So if we don't say we are the junior doctor, we may be mistaken for as the consultant. And you don't want that to happen, okay? You never want to impose a role that is not yours. So you want to say, don't just say I'm the doctor. I told you also in the training course, when you are approaching a patient, they've already told you their name, Samantha Jones, with a question. So go in with some information. Hello, Samantha, can you confirm your last name and your age? It's always so nice as opposed to a doctor who comes in and says, what's your name? How can I help you? Or what can I do for you today? Nice to meet you. No, that is too informal. Try and remain in the level of professionalism, okay? I can see from the medical record you have some concerns. I'm here to address them, okay? And then now, You want to find out the name and the age of the child. As per yesterday, I said we are not calling the baby baby. We're not calling them little kid, little one, all these pet names, right? You address the child by their name and you want to find the age. If you forget to find out the child's name and the child's age, at least, I hope you're not going to remember by the 7th, 8th minute, because sometimes there are things you just have to let go because it'll look bad. But anyway, just sometimes you have to really find out this information and sacrifice looking bad because it is important. So Tommy is not walking. How old is he? He is 14 months. Okay. And has he tried to stand at least? No. Okay. Has he tried to sit up at all? So I'm going through my MILESTON, all of the milestone acronym. Okay, because you want to focus on that problem. Now, has he had any injuries at all? And it is important for me to see, Tommy, where is he? He's at home with his father. Okay, when I do his physical assessment, I would like to look at his legs. I want to see the shape of the knees, the thighs, make sure that he doesn't have any extra folds. So sometimes instead of just saying I'll do a physical examination of your child, it's best to tell the mother what you will do for that physical examination. I want to make sure that his legs are not curving inwards or outwards. There are different reasons why a child may not walk. So that you don't just say it's normal. That's just an easy cop-out, okay? You just don't want to, I'll refer it to the pediatrician, orthopedist or whatever, and they'll take a look at your child. No, it could be from a musculoskeletal origin, it could be weak bones, it could be neurological, okay? So is he having any extra spasms or tightening at all? Does it look like one leg is bigger than the other at all? Do you feel any clicks when you're changing his nappies? When you hold him up, is he able to, bounce up and down? Or does he kick his legs up when you have him on the bed? Or is he just limp and flaccid? Okay, are his toes, is he able to move his toes? Those are the certain questions that you need to ask when you're exploring the condition. I haven't even gone into, how was Tommy born? He was born vaginally or he was born cesarean section. Okay, fine. Were there any complications with the pregnancy? Were any instruments used? Because you're thinking also this could be as a dislocation. But he's 14 months. So what has happened in between then and now? Who takes care of him in the home? Any falls, any injuries? Okay, and then now you're thinking environmental cause. It could be an anatomical cause. Okay, it could be from an injury. And then here's my favorite question that people ask that I really don't find any use. Were you a delayed walker, you or your husband? This woman is 35 years old. You're asking her whether she was delayed in her walking? It doesn't add any benefit. I would want to find out about bone problems, brittle bones in the family, osteoporosis, osteopenia. I would want to find out if there is any osteogenesis imperfecta in the family. So these are the type of things you want to do when you're going into such a station. The age is very, very important, okay? So now let me just go through this. So the patient presents, okay? Or maybe it's a 12-year-old who's coming in and they're limping, all right? And maybe there are other associated symptoms that you found out through old cut. Any history of trauma. Trauma should always be the first differential in pain or in a developmental delay. Okay, yes, then now you're thinking of a low threshold for x-rays. That child may need x-rays, okay? They may need a referral to A&E. So you want to remember, in the pediatric clinic, in the GP clinic, you can't admit the patient there, but you can refer them. Okay, and people get into big trouble because they think, does a GP clinic, do these places have x-rays? Are they able to draw blood? It doesn't really matter. Just say it, okay? Let the rest of the team figure out how they're going to get this child an x-ray and how they're going to draw bloods, okay? And you're also thinking of the NAI, okay? Consider that child. But if there's no history of the trauma, then you want to assess the child on the basis of age, history, and examination. Okay, and now we have just different things, the green, amber, the infection, the red flags, and malignancy red flags here. Okay, I want to go to my red flags first. Okay, they are not able to wait bear. It's a 12-year-old. Okay, maybe the child has pain in moving the joint, they have a fever, boom, urgent. So now you can say, I need to let my consultant know about this. Let me continue asking you some questions. Okay, now once you get to a place with a child who is having problems walking and they are not with you, from what I've just told you, do you want to see them? Of course. A child not walking at any age, yes, the child is 14 months old, but saying to the mother, we need to wait for the child to get to about 18, 19 months before we start to worry. What if this child is having Duchenne muscular dystrophy? What if this child is having a dislocated or a hip dysplasia? What if this child is having a septic joint? You have told a mother that just stay home for 4 months, and if you have any problems with the child, you can bring them back. So why did they come to you in the first place? Very, very key for you to see the child. So Samantha Jones, you've gathered the information. You can even throw in what are your main concerns about this. Does she have any other children? What ages did they start walking? And then now you can go into a little bit of maternal history because you want to focus on this child not walking. Environmental causes could be that she's putting tight shoes and socks on the child. Whenever you put a child, a baby in socks and shoes, you change the anatomy of the plantar surface, so you curve it up. And now the baby is walking on balls. The baby can't walk. And even some of these fancy shoes that people are buying for the shoe is so heavy with such a thick sole. The poor baby won't be able to move those legs. So you may want to say, let's avoid having the child wear shoes and socks in the home. That way, when their foot is flat on the ground, they can get a grip even with their toes. But in socks, you're crumpling everything up. Are they using a walker? Well, there's a myth that a walker assists children to walk faster, but that's not the case. Their walking is dependent on just paddling their legs. Their back is not straight, they are sitting down. So you're teaching them how to walk with bad posture. It can cause posture problems in the future. Okay, it doesn't cause proper bone formation and the resilience that comes to muscle with that exercise. Throw the walker away. In fact, there's no space in your house in London. Okay, another big thing, she may say, I don't have enough space in my home. There are community programs, there are daycare centers, there are safe playgrounds that are in the community. Once in a while, take your child outside. Of course, protect them and just give them the freedom to exercise. Another big thing is diet. So calcium, rich in calcium and vitamin D. These are the things you want your history to be rich in, okay? And in the end, see the child, please, please, please. Beautiful cases here. If maybe a 10-year-old is coming in and they're having pain in their hip. Jimmy, 14 years old, has been having hip pain. All right, you want to find out a BMI. Okay, you may want to, it may present as knee pain. Same day x-rays are essential. Okay, delayed treatment associated with poor outcome. All right, so slipped upper femoral epiphysis. I remember this was such a common thing that were tested on in med school. But it's important for you again to know the age, and associated symptoms will direct you in the correct path. Okay, anything with a fever, you need urgent action. Okay, malignancy, red flags, fatigue, anorexia, weight loss, night sweats, urgent action again. All right, now symptoms that maybe are not improving, then you're still uncertain of the diagnosis, but at least you're going to see that child. So 2 big things I told you in pediatrics: milestones and vaccines. Now, if Samantha Jones, and I remember my pediatric rotation, we had to know all the vaccinations from birth all the way to 12 months. Okay. Now you can go to the clinic and you have nice charts on the wall for you to discuss vaccination schedules with the children. When you're talking to a mother about vaccines, it's not enough just to say, okay, hello, my name is Dr. X. I'm one of the juniors in this pediatric department. I can see my assignment today is to talk to you about vaccination. It's important for us to talk about how old is your child? My child is 8 weeks or 12 weeks or 16 weeks, whatever, okay? Well, an 8-week child needs a 6-in-1 vaccination, and then there's the rotavirus, and then there's the meningitis vaccine. Was your child born vaginally or were they born by cesarean section? You've lost the theme. If I was a mother and I was sitting with you and I came to talk about vaccinations, it's so important for you to ask me what my concerns are, because some mothers are adamant with the movement. No vaccination. Vaccinations are causing autism. The vaccinations are causing other developmental delays. At some point, you want to talk about that issue because it's a social issue that is in pediatrics when it's related to vaccinations. So let's go through this case. So now your child's name is Tommy. How old is he? He's 8 weeks. Okay, how is he doing? He's doing fine. Are you excited that he's around? Yes, he is. Well, congratulations. Every single person who comes, if I'm posted in PEDS, yeah, there's this PEDS emergency. Honestly, there's really no role. As a junior doctor, you are a doctor of all things. Unless you're in a specific trust or specialty, whatever. Anyways, pediatric doctors, yeah, if you are going to talk to the mother and the child is less than a month old, say congratulations. Are you happy that he's around? That's really good. I'm happy he's around too. Or, well, that's maybe a little bit too much. You can just say, I'm glad for your family. Then, how is he doing? Okay. So I usually say congratulations to people who have children under the age of 1. It's a thing that I do out of goodwill. It's not that I'm trying to get IPS. I'm excited for families who have babies. Not all mothers, though, are happy with their children. That's why I always start with, are you excited with this pregnancy? Are you excited that he's around? Okay. I hope he's really made a big change in your family environment. Yes, we've been waiting for him. He's our miracle baby. Okay, where is he now? We are planning for this vaccination next week. He turns 8 weeks. Today, he's with his father. Okay, that's good. So let me talk to you about it. And then even when you come in, when the child is 8 weeks old, I can go over these vaccinations again. All right. So now there's a 6-in-1 vaccine, there's a rotavirus, and there's the meningitis B. I said, when you're learning, and I love this boss baby little character, when you're learning something, learn it with the intent never to need to review it again. Why I remember my 6-in-1 vaccinations is because I know there are 3 of them that are respiratory, okay, that will prevent any respiratory issues. There's one that is going for the liver, and there's one maybe and there are 2 for the joint. So I go 3, 2, 1. And I remember now the 3 that are for respiratory are diphtheria, okay, your Haemophilus influenza type B, and your whooping cough. So now you don't have to memorize these things, just associate them. And then now I'm thinking of hepatitis when I'm moving down on the baby's body. And then the last 2 things, I'm thinking of polio and tetanus from a dog bite, or from the child sticking his sole on a rusty nail. So that's how I associate it. But if you're going to talk to a patient's a mother or a father, effectively, or a guardian, whatever, you want to break it down and say the 6-in-1 vaccine, okay, so there are 6 vaccination in one shot, as opposed to giving your child 6 different needles, okay. The first one is against diphtheria, okay. This one presents as coughing, sneezing, okay. They have, where did I put cups here? Goodness. Oh yes, it can be transferred through cups or drinking substances. That's how I remember it. Okay, sharing of of course, please, not toothbrushes, but sharing of utensils, okay, the child develops a thick coating at the back of the throat. Because you're telling her these vaccinations, you need to tell her the symptoms of the disease so that she can watch out for it, okay? The next one is HIV, or Haemophilus influenza type B. It's spread through infected droplets. It has very many complications, most of them heart, lung. Sometimes it can present as skin presentation of a rash, and even painful joints. The third one is whooping cough. If you want to know your child has whooping cough, it actually sounds like whoop, like a whooping sound, okay? There is shortness of breath and breathing difficulties. And the child has such a big bout of whooping or of coughing that they can even become nauseous and vomit, okay? And then there is hepatitis, which is a virus, all right? Symptoms of hepatitis, they have diarrhea, tummy pain, the baby starts looking a little bit yellow, okay? Polio, it attacks the nerves in the spine and the base of the brain. The patient may have aching muscles, paralysis, very floppy arms and legs. So I am giving your child this vaccine, but I want you to just keep in mind how these diseases present. Do I teach my patients the 3, 1, and 2? Absolutely, and they love it. Oh, that's a good way for me to remember. Now I can sound smart in the mom's club. Yeah, go ahead, Samantha. You can even have a little teaching session with the mothers and tell them the importance of the 6-in-1 vaccine overview. A 6-in-1 vaccine, okay? 3 for respiratory, 1 for the liver, and 2 for the legs. Now, is there any reason why they would not give you a 12 in that? When everybody is coming into this exam and they're just saying, oh, I want to talk to you about the vaccine. Do you know about the vaccines? And there they are looking at the wall. You have the 6-in-1 vaccine, there's the rotavirus, and then there's the meningitis. Forgetting that all this patient-doctor relationship starts with that connection with the eye. You never want to be a doctor who's always just writing things. Memorize, don't you? This is the only job you have. Okay, so your 100% attention should be to that patient. So memorize these things so that at least, not only just for this exam or for your OSCEs and stuff like that, in real life, you'll make that connection. Good. Yeah. Now, other big things, it's important for you to know, just in case you have one of those students who come in and they, brilliant. I really like students who challenge me, okay? The other day I was asked, so which type of meningitis is given at 8 weeks and which one is given at 1 year? They are different. So how do I remember the types of meningitis vaccine that is given in children, okay, in the pediatric population? I know 8 looks like B. You see that association? So meningitis B is given at 8 weeks and multiple again at 16 weeks. So I have meningitis B. Now you'll never have to memorize that. Meningitis B, 8 weeks, and 8 times 2, 16. So 8 weeks and 16 weeks, they are getting the meningitis B vaccine. Wouldn't it be nice if you are in a room with Samantha Jones and she says, how old is your baby, Samantha? They are 16 weeks. Have they received any vaccinations lately? I'm not too sure. At 16 weeks, your child should be now getting the 6-in-1 vaccine and the second dose of the meningitis B. Whoa! How did you know that? Association. It is not hard. Look at that. 6-in-1 vaccine and meningitis B given at 8 weeks. 8 times 2, the same thing again. Okay? And then now you have your rotavirus. And it's important for you to tell her it's highly infectious. Of all these diseases, of all these bacteria and viruses to catch a baby, this one is most likely rotavirus, okay? Highly infectious stomach bug that typically affects babies and young children, causing diarrhea, vomiting, tummy ache, and a fever. It's important for you, Samantha, to have a small safety box in your house, with a thermometer. Okay, you can also have your Calpol just in case the baby is developing a fever. So Encourage your patients to be educated. It will make your job easier the more they know. Why is the population in the UK a little bit more advanced when it comes to medical matters? The NHS has invested a whole website with diseases A to Z that the patients can go and research on their own disease. So when you're talking to people in the hospital, you're talking to people who have some idea of what is going on. Okay, so a country that is for free healthcare saves money if people are more educated about their health. Brilliant. I really hope you get a chance to work here. It's not as bad as people try to paint it to be. NHS is wonderful. Okay, anyways, now meningitis B is recommended for age 8, 16 and 1 year as part of the routine NHS routine. And it's important for you to check that child vaccination program on the NHS also. The meningitis ACWY is for 14-year-olds or anybody who you're expecting to go into a crowded population, like maybe college dorms, they are signing up for the military. So it's important for you to know. And even that meningitis C is given at 1 year. So it's important to know these things in that level. And don't forget safety netting, because people just will go in and talk to the patient about the vaccinations. They'll give the patient the vaccine, and then at around 6 p.m. Samantha Jones is on the phone. Hello, you gave my child a vaccine today and she has a fever. You could have avoided that phone call if you gave her safety netting. Some of these vaccines will cause a little bit of tenderness to the site, a little bit of redness, okay? You don't want to disturb that area or even rub the area at all. Just be a bit gentle when you're washing the child. Fevers, slight fevers are expected after vaccination. So it's important for you to have some Calpol in your safety box. Give the child a little bit of Calpol if they're developing a fever. Of course, you don't want the fever to get to a point where the child is becoming febrile, having a febrile seizure, okay? But now you see, you've taken care of the present. You've taken care of the past. The present involves talking about the vaccine. And if you're doing the Plab, I teach in my sessions, you have to be a good time manager because you can't use just 6 minutes talking about vaccines. You want to at least use maybe how do I usually teach it? 3 minutes for data gathering, 3 minutes for data gathering, 2 minutes for a physical examination and even adding of investigations and labs and all those things, and then another 3 minutes of management. In this 8-minute station, okay, so you're walking in, you're talking to the patient, you're getting your rapport, but you just can't focus everything in one section. It's important for you to divide your time properly. And if you get the alarm, move 2 minutes remaining, you know it's time for you to wind up. I would ask the patient if she has any concerns and I would give safety netting. The biggest thing with vaccines, please, is paying to the site and your fevers. Okay, so don't forget this stuff. It's nice and easy. Explain what the condition is. Is it a virus? Is it a bacteria? What are some of the presentations so that the mother can know I'm doing a good thing by vaccinating my child. Okay, good. Now, first antenatal clinic. Today I have to really be careful about our time because I want us to do some mocks. Yeah. Now, since we are still in the environment of mothers and their children, I decided to add this scenario from your blueprint. You need to know first antenatal care visits and what happens in such environments. Okay, it is also called the booking appointment. So you could have a station in the future that says Samantha Jones, 35 years old, has come for her first booking appointment. Address her concerns. What is a booking appointment? I have no idea. Tea time, yeah? It is also called a first midwife appointment, okay? They usually get an invitation letter before 10 weeks. So this schedule is done The first antenatal care visit for a pregnant woman is done by 10 weeks. It can happen at the GP clinic, it can happen at the antenatal clinic, sometimes they can even come to the home, okay? A midwife can do it also, a physician can do it also, but it is important for you to know what is important because it is a big case, okay? Now, hello Samantha, my name is Dr. X. I'm one of the junior doctors in the antenatal clinic, okay? I can see from my note that you are now 10 weeks pregnant, okay? Is this the first time we are seeing you? Yes. Oh, forgive me, I needed to ask your date of birth and your last name, please, just for confirmation. It's fine. If you forget, signpost back and ask the question. I'm Samantha, I'm 35 years old. Yes, I'm 10 weeks pregnant. Before you start your hallelujah, oh, congratulations, just say, in general, how are you feeling about the pregnancy? I'm happy, doctor. Okay, this is good. Congratulations. Is this your first child? Yes, it's my first child. Okay, that's really good. Did you come here by yourself? Because you're trying to find out who is her support system. No, my husband dropped me off, or my partner dropped me off. Do not assume the partner is of the opposite sex, because people get into trouble even in real life by saying, okay, are we expecting your husband soon? Why did you assume, doctor, that partner is husband? Partner could be wife and wife. So please don't bring your international biases to this country. And people really get marks off in OSCEs and in examinations for just assuming that a woman is married to a man. Okay, gone are those days, right? We're living in a different world now. So, who brought you in? My partner. Is your partner going to be joining us anytime soon? If they are, I can just repeat this information again. All right. So you're 10 weeks pregnant. You're excited about it. It's your first child. General overview. It's so wonderful for a doctor who comes in and is interested on social medicine before medicine. I hope you understand what I mean. Because a doctor is not just a physician. You are a big brother, a big sister, you're a mother, you're a father, and you have to balance these things out to show that you are human also. It's not always just going directly to the lab work and let's discuss the lab. Let's discuss why you're here in the first place. No, you want to find out, okay, so how have you been doing? Especially now in this COVID era, is everything okay? You know, how have you been managing at home? All right, are you still working? These are just the general overview things. Are you eating well? Are you sleeping well? How many hours of sleep are you getting? What do you do for work? And now when you're actually going to ask the past medical history, including occupation and all these things, please don't re-ask questions that you started with in the beginning, because it shows you're not paying attention. You're being just robotic. And sometimes people have been called out in an exam. You ask a patient, what do you do? I work in a bank. Do you like your job? I love my job. You know, it's not stressful. Okay, that's really good. When was the last time you took a vacation? Oh, I haven't. You know, at least now with maternity leave coming up, you will have a chance to, you know, get a bit of a rest. And then down the road, you ask her, do you smoke? Do you drink? What do you do for a living? She'll be like, I told you a few minutes ago, I work in a bank. So it shows you're really not focused. You're just there to gather data. So always try and start your stations as long as they are not emergency cases, and we'll handle a bit of emergency maybe tomorrow. Not tomorrow, maybe the day after, yeah? If it's not an emergency, you don't have to manage. So just build your rapport around natural things and be natural about it. But don't spend all the time on rapport, because then it looks a bit creepy. Where do you live? You live in Manchester? Okay. Oh, why me too? What street? Oh, Home Street. Okay, there you like my creepy doctor asking too much. 30 seconds and you're done. All right. Now, let's go back to the pregnancy. So you're focusing on the pregnancy. How was this confirmed? I did a urine test. Okay, so is this the first time you're coming to the doctor? Yes, yeah. 2 months? Is there a reason why you've delayed up to 2 months? No, I'm really busy, blah, blah, blah. It has to be confirmed with a blood test, okay? Now you found out about those emotions earlier on, okay? Any concerns in particular? No, doctor, I was just told by my GP to come and start my antenatal care with you. So this is the antenatal clinic. I'm one of the junior doctors. You're going to have a very big team of support. You know, we have specific people to support you throughout the pregnancy. You're going to meet midwives, there's consultants, registrars, there are the junior doctors, and wonderful nurses. And there's so many resources available for you. You know, especially this being a first child, we want to make sure that this is a good experience and that all your questions will be answered. Now, where would I go next? The milestones of pregnancy. Okay, I would get into trimesters. It's her first child. Even if it's her fifth child, you can just say, let me just go a quick overview of pregnancies, okay, just to make sure we are on the same page. The whole pregnancy is divided into 3 trimesters, and there are certain milestones we are looking to accomplish in each. Okay, so in the first trimester, the baby is developing, they are getting their organs, okay, their organs are developing. You may feel a bit nauseous, tired, fatigue, frequently running to the bathroom, bit of constipation, you know, so it's important for you to continue with, you know, a bit of exercise, and also your diet has to keep, you know, in mind that you're now eating for 2. Okay, there are various weight changes that we propose for in pregnancy, because generally you can gain up to 10 kilos. But according to your height and weight, we calculate a BMI. And if you are on the lower end, less than 50 kilograms, then we would want you to gain a little bit more weight than 10 kilos in the pregnancy. But if you're on a bit of the higher side of weight, like 100 kilograms above, I remember this stuff, I don't know how. Okay, 100 plus kilograms, then we would want to focus your weight gain in the pregnancy to be a little bit more controlled. Only because there are some associations with the pregnancy being a bit high risk if you put on a lot of weight. And I can even talk to the dietitian who can come and speak to you about, you know, some of the foods that are important for you to eat. Since we are talking about food, can we talk about diet? Yes. What's your regular diet? What are some of the foods that you eat? I eat chips, fish, sausage, all these other things. Okay. Well, in moderation, those foods are okay. Please add vegetables to your diet and a good fluid intake. But there are some specific foods. Since you mentioned you eat meats and fish, my grandma, meats and fish, it's important for you to know any raw undercooked meat, fish, okay? And why did I ask her, what does your diet consist of? Never go into any scenario and just start telling people, don't eat meat, don't eat fish, don't eat eggs. Some people will just be like, oh, gosh, I don't even eat those things. Then you're left stuck, looking crazy. I don't want you to eat meats and fish. I only want you to eat white chicken. I don't eat chicken. Well, I eat chicken, but I don't eat chicken. So some people will be thrown off by such statements. Never, never assume. Because this is a big case, you're just touching on very important highlights. Okay, you've now talked to her about some different causes of other, you know, important risks that can be caused by eating undercooked fish, meat, but you found out what her diet is. Okay, some conditions can be caused, or some bacteria can be spread by undercooked meats, undercooked fish, undercooked eggs that are very harmful to a developing child. Okay, so in your first trimester, we want to make sure that you're on board with all these things, including safety during pregnancy, managing your nausea, managing your fatigue, pacing yourself. In the first trimester, we will do a dating scan, okay, just to make sure that we can estimate an accurate date of delivery. Now, do you, has this been done before? Did anybody calculate it for you? No, doctor. How easy is it to calculate the Naegele's rule? the Naegele's rule, depending on where you went to med school. Yeah, it's nice and easy, and sometimes, of course, not to show off to the patient, but just to give her an average. So now you're saying your last menstrual period was on this date. Yeah, guys, you just add +9 to the months and +7 to the dates, and that's it. You get your expected date of delivery. But you can only, when you use this just to tell her when to expect the baby, it's important for you to mention this method is used if you are on a regular 28-day cycle. And sometimes this rule is really not that accurate, and the date is 2 to 4 days early. So we want to always give or take 2 to 4 days. There's another way you can do this calculation: -3 from the months, +7 of the days, and +1 year. But literally what I do, I just add 9 months and 7 days, 280 days from the last date of their period. Nice and easy. Don't be the doctor who's like, there's an app for that. Really? Leave all these apps. You show them medicine comes from inside, okay? Now, with this scan, can also show that the baby is in the right place. You never want to scare a patient in the first visit of pregnancy. So be very careful about throwing words like abortion, Down syndrome, miscarriage. Of course, those are things we are worried about, but this is her first visit. She has 9 months to talk about all these things, okay? Then now you can go to your second trimester. You may feel a little bit more energetic. Use your time well because you have energy. On days that you have energy are the days where you want to really, do more. And the days that you're feeling tired, you want to take a break, okay? Now, your circulating volume will increase to about 50%. You may be aware of your heartbeat. You may find that you're becoming a little bit short of breath. You may notice changes on your body. Some women develop a line in the middle of the abdomen, the linea nigra. Okay, you may hear that there are some different methods to prevent stretch marks. Most of the time, the stretch marks will may remain after the pregnancy, but you can, regular lotions are still fine, okay? What are you thinking about in this second trimester? The 20-week scan to check the heart, the bones, the face, the kidney, abdomen, and the spinal cord. Done. Third trimester is towards the end, and we are watching for conditions that can really affect the pregnancy and result in maybe an early delivery of the child. Okay, and even around this time, we'll start talking about what you want, as a form of delivery, cesarean section or a natural birth. And I can even have one of our midwives talk to you about this in more detail. The third trimester is where we are going to do some tests, okay, to check for specific infections, all right? Especially one to check for diabetes. Do you have any medical conditions? Diabetes, high blood pressure? No. Any diabetes, high blood pressure running in the family? Not at all. Okay. Do you consume any alcohol? No. How about smoking? I used to. Very good. So you do not smoke. That's really good because alcohol and smoking have been associated with complications in pregnancy. And even children who are born really small and their development takes a little bit longer to achieve, during life. So I'm really glad you don't drink and you don't smoke, okay? First trimester, we are going to start on folic acid and vitamin D, okay, to help the development of just the neural function of the child. I've been talking so much, Samantha. Do you have any questions for me at this time? No, it's so overwhelming. There's just so much for me to learn. Yes. And most of our mothers say that there is just so much. This is why we'll give you the contact information, our telephone numbers. You can even call, if you're concerned about anything during this pregnancy, anything that is worrying you, there are some numbers you can dial, like 111. Okay, I want you to sign up for some of our antenatal care classes where you meet other expectant mothers, build some relationships so that you're not just having this journey by yourself. let me look into some of the community services that are in our community that can even just help, okay, as a support. There is this program called Start for Life. Yes, it's online, it's a website. You can sign up for weekly emails. They can give you detailed information, and it's actually approved by the NHS. Detailed information about this pregnancy, what to expect. There are some videos, there are some tips, yeah. And I want you to know that the pregnancy is, as much as it is important for you, it is important for us. We want these 9 months to be exceptional for you. So even as you progress with the pregnancy, we may invite you for more frequent scanning if we have our concerns, okay? Now, where would you go with your safety netting with this woman? There are so many different things to say, but what thing do you want to make sure you tell her? If your water breaks, if you have fever of any kind, all right, if she's noticing any vaginal spotting, any abnormal discharge, it's important to come back to the emergency room. Cramping, so in the 3rd trimester, she may have the Braxton Hicks contractions, which are irregular, spontaneous, they are not consistent, you know. So if you do feel like you're having a bit of a cramp in the stomach, I would time it. If you're having consistent cramps, like a contraction every 5 minutes, you need to come to the hospital, okay? Now, other things, what do you want to do? Headaches, increased swelling in the legs, blurry vision. I can print out some written documentation that you can refer to, and even in the next appointment, we can discuss this again. So for your first antenatal care visit, now I'm talking management, because you've collected your data, you've done your teaching, the 2-minute bell has rung, you're like, oh gosh, I haven't done management. You want to switch. What do I need to do for her? We've already done a simple calculation on when to estimate the date of delivery. What labs do we need for her? We need a urine dip, we need full blood count, UNE, LFT, RFT. We will check your blood for anemia. We'll check your kidney function, your liver function, the balance of your electrolytes, sodium and potassium. These salts are very important to keep in normal balance, okay? We'll check your blood pressure. We'll compare your height and your weight to see your BMI, as I had mentioned before, okay? It's important for us to do some certain blood tests to see your blood type, okay? And to check for other infections that can be dangerous to the baby, especially hepatitis B, hepatitis C, and HIV. Never just throw HIV to anybody without shielding it in hepatitis, okay? Now, do you have any questions for me? No? I'll let my consultant know that you're around. Since it's your first day in the antenatal visit, I'd like us to, for me to introduce you to the rest of the team so that you can know who is here to support you. Can you give her a tour of the place? Well, in real life, that's what you do. I'd walk out with Samantha, I'd introduce her to Nurse Betty. This is the reception. Let's pick up a couple of pamphlets for you. This is my consultant. We have our registrars. These are a couple of the rooms where you will have your examinations. And now we can stop here and do your height and your weight and continue on. Bravo. Now, let's do this. Perfect. Our mocks are going to begin. In real life, honestly, examinations are actually fair because they kind of give you a little bit more information that you get in real life. In real life, you could be in the emergency room and the red phone rings and you're told there's a patient who's coming in with a trauma. You have no idea. Maybe they were hit by a train. You already need to know what you need to have prepared because you're in the emergency room, okay? In real life, you are a doctor and a sick person walks in through the door. So now if you're in an examination station and they are giving you all this detailed information, it's for your benefit. Use it wisely. Let's do this. Let's go on our 10-minute break and then we'll come back and we'll start our mocks. Do I have them here? Good. And during the break, let's see, I'll give a question, and the first two people who give me the correct answer will get a chance to do the mock with me. So let's go for a 10-minute break, and then we'll come back and then we'll do the mock. Okay? See you soon.
Okay.
And I will give you the question to read, and then I will let you know when you can start. Ready? Okay, here's your question.
Yeah.
Okay.
Okay.
Tell me
Okay.
when you're ready. Are you ready?
Yes, yes, doctor, I'm ready.
Okay.
Enter station.
Hello, my name is Dr. Amina. I'm one of the junior doctors in the department. Are you James Smith?
Yes, Doctor, I'm James.
Okay. So, James, what brings you here to the department today?
The ambulance just picked me up. I guess, I don't know. I was just outside, I fell outside the bar.
Okay, yeah, I can see from my notes that you felt unconscious in the street this morning.
Oh, wow. I didn't know. I didn't know.
You didn't know about it. Okay.
No.
Do you
Uh-oh.
do you remember what happened?
I don't
Hello.
remember. I don't remember what happened. 1 minute I was just trying to cross the street,
Okay.
and the next minute I was in an ambulance. They were calling me. Yeah,
Okay.
I don't
Okay.
remember.
Okay. How are you feeling now, James? Are you okay? Are you comfortable talking to me?
Yeah, the room's just still feels a bit hazy, but I feel like I'm okay.
You feel like you're okay. So, James, before I proceed, I would like to put you on the monitor and I would like to check your vital signs. That includes your blood pressure and your heart rate. Is that fine?
Yes, doctor. The examiner says the vital signs are stable.
Okay, vital signs are stable. Okay, James, that's a good thing that your vital signs are stable and everything is going on normal. But there are a few questions I would like to ask you in order to provide you the appropriate diagnosis and management. Is that okay, James?
Yes, doctor.
Okay, so James, as you don't know what actually happened. So James, is it the first time ever that you come to the hospital or anything like that happened before?
This is the first time. Nothing like this has ever happened.
Nothing like that has ever happened in your life.
No.
Okay, James. Um, do you feel any kind? Can you tell me a little bit what you are feeling right now?
It's just I'm like not myself. The room is just a little bit, a little bit spinning, a little dizzy, a little, but I don't know. I think I'm okay. What happened? What's going on? Can I go home?
I'm still trying to figure out what is happening with you. There are a few questions. For example, do you feel any? Do you feel throwing up, or do you nauseous at all?
I felt a little bit nauseous, but
Hello.
yes, I felt a bit nauseous.
Okay. Did you throw up? Do you remember?
No, no,
No. Do you feel any fever?
no.
No. Any pain in your body at all?
I think just a little bit on my side here, maybe where I fell down.
Okay, okay. Do you feel, did you notice any bleeding?
No, no, no.
No, you didn't. Okay.
My mouth
That's
had,
good. That's
my
good.
mouth tasted a little metallic. I don't know why I have that funny taste.
Okay, okay, John. I can see. John, have you been diagnosed with any medical condition?
No, doctor, I've never been diagnosed with anything. Hello?
High blood pressure?
No, doctor, no high blood pressure, no. Hello?
No. Okay. Do you have
Hello?
hello?
Oh, sorry, I didn't hear. I think you're losing
I'm
connection.
so sorry.
No problem. Do you want to repeat the question?
Yeah, are you non-allergic to any kind of medicines or food?
No,
At
doctor. No, I'm not
no,
allergic. No, no.
no. So, James, what do you do for your living?
I work in a bank.
You work in a bank,
Hmm?
and do you live alone, or whom do you live with?
I live with my wife and my 2 children.
Okay, so are they here with you?
No.
No. Did you call them, or did you told them that you were in the hospital? Or if you want us to do it for you?
Oh, please, yeah. My wife must be very worried. Yeah.
Yeah, okay, don't you worry. We will call her and we will let her know about your condition. Okay. And anything else you would like to tell me?
I don't know. Am I okay to go home?
Well, James, as far as right now, I can't tell you that you can go home or not, because we're still trying to figure out what's wrong with you. So for that, for the time being, I need to we need to put you under observation, and we would like to do further investigations and further tests in order to rule out your proper diagnosis. Is that okay?
Okay, okay.
Okay, James. Am I making sense to you? If there is anything you didn't get, you can ask me now.
What do you think is wrong with me?
Well, James, as you told me that you had this sudden spell of unconsciousness, and as far as your vitals are concerned, I thought we were thinking of something like you got an attack of you might be your blood sugar has gone down, or maybe sudden loss in your consciousness that lead to a sudden loss in your blood pressure that had lead to this spell of unconsciousness.
Okay.
But John, can you tell me when did you had your last meal?
Oh, I haven't eaten last night.
Last night,
Mhm.
and you didn't eat up till now since the morning. You didn't had breakfast and all.
No.
No, you didn't eat. So I guess that's the reason. That's the reason that had caused you this sudden loss of consciousness, unconsciousness. So do
Oh,
you feel like eating at this time?
I think so. The room is still a little dizzy, spinning, but
Okay.
I guess I just have to wait.
No, you don't have to wait. I will would you like to have something like some sandwich and some coffee if you like? I
Oh,
would
okay. Yeah. Thank you.
yeah. Yeah, I'll just we will
Am I
just
going to die?
James, no, you're not going to die for sure. As I told you that we are going to do the further investigations, and we would like to know the root cause of this.
Move to your next station.
Okay. Good. I am so glad you have taken the chance to do this.
Because there are lots of mistakes, I know.
No, it's good. It's good because now everybody will be able to learn. And I want to see what people are thinking about this case. If you were to do this case again, what would you do differently, Dr. Amina?
Me.
Yes.
Yeah, if I would have to do this case, then a few questions I asked at the end, if you eat something or not, I would have asked in the start.
Good.
The vitals. When I told you that, are you feeling okay? I would like to put you on the monitor. I would have done it after when you told me that I felt unconscious. I don't remember, so I would
Yes.
have done it
Good.
secondly. Third thing is because I was really not able to get the diagnosis. I thought that you were diabetic and that's why you had this hypoglycemic attack. I
Yes.
would have checked your blood sugar. I forgot to
Very,
check.
very good. And that is a big mistake that I flagged you for, because you checked my vital signs at 1 minute and 52 seconds. So I usually, when I do the mock, I always put like a time frame so that the doctor can say, oh, okay, I did waste a bit of time with the vitals. I should have checked it earlier.
Yeah.
He's showing you he's still not very stable. And anytime you see somebody who's not stable with vital signs that are normal, always do the blood sugar.
Blood sugar, yeah.
So I gave you a kind of tricky case, because when I had to do this case when I was training, I failed it and it made me shocked. So I hope you've gotten the shock effect.
I got it already.
That now you know vital signs. If normal and the patient still looks unstable, check a blood sugar. Because you see now, I could have twisted this case to be anything. I could have made it hypoglycemia, blood sugar is 2.1. You see, and
Yeah.
I could have twisted it also to be a seizure disorder, because you asked me what is going on. I said I feel like I have a metallic taste in my mouth. Usually that's how people describe blood. So maybe I bit my tongue when I fell. The area of injury I said was around this side, so maybe I hit my head, and maybe I'm having like
Yeah, then I would have asked if you feel any weakness at all.
Yes, good. And so your questions were good, but then you called me James 1, 2, 3, 4, 5, 6, 7 times.
And I didn't confirm you that what should I call you.
Yes, and you changed my name to John 2 times. So you it's so funny. Even sometimes I tell people my name is Melissa, and I don't know, during the station they start calling me Samantha.
I got it.
It's something, it's good that we did it, because now you can be aware of it. Saying the patient's name too many times is maybe not too good. I usually just say once in the beginning, once in the middle, and once in the end.
Okay.
So you're not just saying James this, James this, James the other, James the other. And don't, by all means, do not confuse names. So I have a pathology of forgetting names. So I usually just use patients' names once in my sessions. And then if I can get a chance to see their name again, I will pick up the paper and then call them a different name. Okay, now when you say management, you said we're going to do some observations and some tests to rule out. Do not be vague with management. You want to specifically do, say, okay, let's keep you on the monitor. We'll keep checking your vital signs. I want to do a physical examination. So now you're thinking, do I need to check his pupils? He had a fall. Do I need to do some specific blood work? Let me check a blood sugar. Let's do the rest of his labs. He could even have sepsis. We don't know.
You could know.
And then the vital signs work. Let's just do a whole blanket of lab work. Electrolytes, liver, kidney. Let's do infection markers. Let's also do the blood sugar. And then what imaging do I want? He has fallen. He may have had a seizure. So let's talk to a neurologist. Let's do maybe an inspection of his mouth. Let's check the injury, where he fell. This is how now you get points for management, by being specific. And you still had time, but you just said we'll just do some tests to rule out. So in the future, just be a bit more specific.
Okay.
Yeah, I'm happy you told me you'll call my family for me. You'll give me a sandwich and a little bit of coffee. And that would maybe give you some points with the IPS. But in this case, what is very important is how to manage from the first 2 minutes.
2 minutes.
Okay. Good. Yeah, good job. You guys should be telling her, yes, good job. Good attempt, Dr. Amina. Any other advice you want to give her? I said here that I think the best thing is that immediately after reading the question, one should quickly list out 3 to 4 differentials in your head, okay, and then follow through that line. That's also another good way to follow through. Yeah. But another thing also for a pointer is easy cases are usually poorly done. Because either we go in, we're like, I think I know what this one is.
We know the diagnosis already, so we are just going up with only their questions. We don't go for the differentials and all.
We don't go for differentials. So be very, very careful with just easy diagnosis. But thank you so much for volunteering.
Thank you so much, Dr. Lianne. Thank you so much.
You're very welcome. You're very welcome. Okay, so who is the next one? I think it was Dr. Stella. Anybody else has any more input for Dr. Amina? Just type it in and then she can take your feedback. All right, now Dr. Stella is up next.
Yeah.
How are you, Dr. Stella? Are you ready?
I'm fine. Yes, I am.
Okay, good. So let me make sure that you can hear my timer.
Enter station.
You can hear the timer? Hello? Dr. Stella? Hello? Dr. Stella?
Yes, I'm here.
Okay,
I'm here.
Were you able to hear
Yes, I'm here.
Were you able to hear the timer?
Enter station.
No, not yet.
No, okay.
Yes.
Okay, good. So there's a bit of a lag. All right. So let me put that down and then let's go to now your station, and this is your question.
Okay.
Okay, and here.
Enter station.
Hello.
Hello.
Yes, this is Dr. Okoro, one of the junior doctors in the emergency department. Are you Samantha Jones?
I am. I don't want any junior doctor, please. Can you just get me a consultant?
Well, what would you like me to call you first?
My name is Samantha Jones.
Okay, you want me to call you? What would you like me to call you?
Just call me Samantha. Do you have any consultants, please? I want somebody who is like an expert. You know, you juniors really scare me.
Okay, Samantha, I understand your worries. However, my consultant will be with you in a moment. Can I just get what brought you to the hospital before he comes? Is that okay by you?
Yeah, I have a bit of a headache.
Okay.
Yeah.
Before we go into that, please, Samantha, can you confirm your age for me?
Oh, I'm 65.
Okay. So you were telling me about the headache. I'm sorry about that. That must have been really distressing for you.
Yeah.
So sorry. Can you tell me more about this headache?
What do you want to know exactly?
Sorry?
What do you want to know exactly about my headache?
Okay, when did it start?
Oh, it started maybe 2 weeks ago. It's just increasing.
Oh, so sorry about that, Sam. Are you comfortable to talk, or do you want some painkillers?
I think I can manage. I just took some paracetamol 10 minutes ago.
Okay, Sam. In a scale of 1 to 10, with 10 being the most severe headache you've had and 1 being the least, can you grade this pain for me?
It's about maybe 5.
Okay, so we can continue?
Yeah.
Okay, and where exactly is it located in your head?
It's just, I honestly feel it all over my head, but it's just mostly on this side.
Okay, so sorry about that. This one, you're wincing your eyes, and is there any problem with the eyes?
It's like it's a bit blurry, you know.
Oh, so sorry. Do you mind if I dim the light for you?
Oh yeah, thank you. That would be good.
Okay, Samantha. Are you comfortable now?
Yes, a little bit.
Okay, so we're talking about this. Was there any time, what have you done anything that made you feel relieved of this pain?
The paracetamol helps a little bit, but I wish I could know what is going on.
Okay, so sorry. And has anything worsened the headache?
No, not really. It's just continuous, you know.
Okay, so sorry about that. Have you noticed any stiffness of your neck?
No.
Okay, what about probably when you want to comb your hair? Have you noticed maybe you find it difficult lifting?
Lifting?
Having pain? No,
Yes,
having pain combing the hair?
combing. You know, my hair is in these braids. I don't comb. But when I oil my face, it's a bit tender.
Oh, so sorry about that, Sam. When you eat or when you eat food, do you notice you have pains in your jaws?
It's a bit tender, a bit tender.
So sorry about that.
No, I
Okay.
can't
Have
see.
you can
Yeah,
see?
yeah. I was able to see, but now.
Okay, you can. Oh, so sorry about that. We'll get to that very soon. Okay.
Okay.
Yes. Do you notice any rash in your body?
No, doctor.
Okay, Sam. Prior to this, have you had any medical condition that takes you to the hospital?
No, I've been healthy. You know, I try to eat my small cabbage here and vegetables.
That's a good one, Sam. I must commend you for that.
Mm.
Are you currently on any medication?
No.
Okay. Are you allergic to any drug at all? Any known medications?
No. Did you turn off
Oh,
the
Sam, I
light?
can see that I've turned it off. I've dimmed it, Sam.
Oh, because it's all black. I can't see.
Oh, I think I need to, let me
Why?
examine you now.
I can
Let me
see.
examine you now.
Okay.
Yes, I want to be checking. First of all, I want to be taking your observations.
Okay.
I will take your heart rate, your breathing rate, your heart rate, your oxygen level, and your temperature. I want to be checking your eyes. I'll be using an instrument. Okay?
Okay.
What I want to do is that I want to be checking the back of your eyes. First of all, I want to assess if you can see properly my hands.
Yeah, I can't see from this eye. I actually thought you turned off the light.
2 minutes remaining.
What's going on with me, doctor? Help!
Okay, Sam, not to be alarmed. First of all, I think from what you've told me, I think you're having giant cell. I think you're having a condition called giant cell arthritis.
Giants? I don't know.
Well,
They're giants?
No, the name. Sorry about that. It's a condition where there is an inflammation of an artery in your brain. As there's an infection, something is going on in a part of the artery in your brain, and it's an emergency because I can see now that it's affecting your eye vision. So I'll be sending a referral, a consult to the ophthalmologist so that they come see you immediately. Is that okay by you?
Okay, okay.
Yes, and my consultant will be coming very soon because I have informed him of this situation so that we can act as fast as possible. Is that okay?
Okay, no problem.
In the meantime, are you still having any other pain? Are you still having the pain?
Yeah, around my eye.
Okay, we'll give you some medication first of all, okay?
Okay,
We want to be admitting you, Sam. Is that okay by you?
okay.
Okay, thank you. I will be giving you some leaflets about this condition so that you read pending when my consultants arrive.
I can't read because I can't see.
Oh, sorry about that, Sam. I forgot.
Huh? So what's gonna happen?
The ophthalmologist will come and assess you, and he's going to be giving you a medication so
Which
that we
one?
give
More
a
paracetamol.
steroid.
Okay.
A steroid.
Move to your next
Move
station.
to your next station. Good. I gave you a nice hard case. And I was trying to check and see how whether you can see some non-verbal. Okay, let's start from the beginning. Let's start. Thank you, Dr. Stella.
Thank you.
I do enjoy my second non-paid career of acting. I should have done acting before. All right, so Samantha Jones has come to the emergency department. She has some concerns, yeah? She has a headache. Now, she told you to call her Samantha, but you became very good friends with her and started calling her Sam. So try not to shorten the name of the patient, yeah? Let's see what other people are saying here. Lord Trouble, which eyes will I use? Okay. Now, if you were to do this station again, what would you do different, Dr. Stella?
Okay. First of all, I feel, you know, the eye you not seeing well, I didn't reassure you because you had already come with the eyesight, okay, to the hospital. So it's not like, it's no longer, yes, it's an emergency, but you kept putting it to my face and maybe wanting me to act on the eyesight first.
Yes. Yeah. So maybe getting it a little bit earlier, and any conditions with the eyes, very important for you to alert earlier ahead. Because at first I said, okay, I have a headache, and then I was not even trying to trick you that it's GCA. From the word go, you were able to check if it's meningitis. You know, I would have thrown in another differential, maybe stroke, weakness on the side of the face because of her age. I think I said she was between 55 and 65, yeah. And then the dimming of the light, you said at 2:59. And I felt like you got stuck at some point. And now this is a good lesson for even everybody. And I also use this myself, yeah. If I feel like I am getting stuck, I always think, how can I not show that I'm stuck? Because you don't want a patient to think that you're stuck. I always throw in a question. Okay, what are your concerns? Do you have any questions at this time? Meanwhile, I will try and unstick myself by covering up that, you know, does the patient have any concerns? Do they need any clarifications? Or do you have any questions? Yeah. The beginning was good also. Me saying, I want a consultant, I want a consultant. At least you didn't take that one to heart, because some people get a bit upset. I'm the doctor. Why do you want another consultant? It's good to say a little bit more, okay, I hear that you want a consultant. I am part of the team. As soon as I just make sure that you are not in any emergent condition, I will have my consultant come in and review. Okay? But it's important to have, as soon as you figure out it's GCA, boom, quickly ophthalmology. Yeah? And it's not even just to say, you can say, okay, I'll refer you to the ophthalmology department, but it's best to say, to show the emergency of it, I will have the ophthalmologist on call come in and take a look at you. What side is it? It's on my right side. And because you have said you're having pain in the eye, trouble with the jaw, there's a bit of blurry vision, and you're also having a headache, I need to also draw my lab work at this time. So this is another very easy case, but people are not very specific in the type of labs that they want. Yeah, you want to say, of course, your full blood count, ESR, CRP, those two big things, ESR and CRP, so that you can check those inflammatory markers. Let me even, where is that? Good. I have my NICE guidelines. My NICE guidelines are open. GCA is a medical emergency, urgent referral for even a suspicion. Okay. Now, if there is vision loss, transient or permanent, again, urgent referral. So that's one thing I was wanting, I wanted you to say, yeah? Now, a big thing would have been also is, of course, you did your maftosa and all these other things, but for management, it's good for you to say, we will, because we have a high suspicion of GCA, and even the explanation, because you just said you have giant cell arteritis and you kept quiet, you'd have been flagged for language, medical jargon. Because I was asking you, which giants? I don't see any giants. No. How I try and avoid being flagged for medical jargon is I can say, you know, you have a vessel literally at the, you have some vessels in the brain, okay? Sometimes they can become very, very inflamed, okay? Because of various reasons. What we need to do is to check to make sure it is not an emergency condition called giant cell arteritis, which affects specifically some of the vessels in the brain. So you've hidden the medical jargon in the explanation. But don't say medical jargon and then keep quiet, because they'll be like, language. Yeah, good. Now you also said leaflets. Leaflets are mainly for people who you're going to discharge. So because this is an admission, you don't want to say about the leaflets. But let me talk to you about the nice guidelines with the treatment of suspected GCA. It's oral prednisolone, and you have to mention that anybody with visual symptoms, it's 60 to 100 milligrams, okay, and ophthalmology within that 24-hour period, 60 to 100 milligrams. If it is no visual symptoms, then it is between 40 to 60 milligrams. Okay. Now, other things they say, consider arranging the following tests. Start, do not delay referral while awaiting the results. You want to make sure you check liver function tests, because some people with GCA have a mildly elevated alkaline phosphatase. Okay, and then now we have full blood count. They may have a normochromic normocytic anemia and an elevated platelet count are usually common in this condition. Okay, CRP, the level is usually elevated and may be more sensitive of inflammation with people with GCA. Okay, and then ESR more than 50 mm per hour. Okay. But ESR is really not that sensitive. But the big thing is the meds, the ophthalmologist, and even the pain. Now, let me see what other people are giving you for advice. It's really good that you've offered to do these mocks, because now, whenever you do a mock, even with a friend of yours or a colleague, before they can give you feedback, you want to ask for an opportunity to see if you made a mistake. What would I have done differently if this was the case? So you can correct your errors. That way now it can stick. And then afterwards, then they can give you the feedback, okay? Let's see. You are not nice at all. I threw her off. Yes. And that is what I want to do. In my mocks, I try and scatter you to see if you're robotic. And it's good, because if my mocks are harder than the exam, then you'll be in this exam saying, these people, they should go for acting classes. Yeah, the exam can be very, very unstable. You have a patient who is okay talking to you, 2 minutes, they're dying. You have to be able to dance. I don't want to start showing you my dancing skills. Yeah, you want to be able to adapt. Yeah. This patient, suspicion of GCA ophthalmology, I will let my consultant know, because you have vision problems. It's important to start you on a high dose of steroids between 60 and 100 milligrams. That's what you want to say. Okay, then you can continue with the management. Please. Can I please repeat the management of GCA? Okay, let me read it to you, because some of you do not have access to CKS guidelines. They say urgent referral for suspicion. Visual loss, transient or permanent, ophthalmology on call. They have to find an ophthalmologist for this patient. They need to come in, okay? Now, immediately treat people with suspected GCA with oral prednisolone. And how you want to say that is, I need to let my consultant know, because we will start you on a high dose of oral prednisolone, 60 to 100 milligrams, because you're having vision problems, okay? Now, and then people without visual problems, at least it's a little bit lower, 40 to 60 milligrams daily. Where people make big mistakes here is they start saying, okay, when you've started you on the prednisolone, I want you to know safety netting. It can cause porosity in bones. It can cause you to have a lower threshold for infection. You can have nausea. I want you to take the, what are you talking about? You cannot, you cannot start giving you cannot start doing these things. And when I usually give this case, I usually laugh because I'm like, why are you telling me safety netting with prednisolone? Can we first focus on this GCA? First telling me about the management, if you can give that prednisolone in, and if they can have ophthalmology in, there are chances that you can reverse the visual loss. But never be trapped by a patient who will say, will I be blind forever? Chances are you may be blind. Chances are you may recover some of your vision loss. What is that answer? Very ambiguous, but it's hopeful. Okay, you're not trying, you can say bad news in a good way. So don't try and make the patient feel really, really bad about it. Okay, anyways, good job, Dr. Amina. Good job, Dr. Stella. I didn't get a chance to say goodbye to Dr. Stella, but that was a good attempt. At least now we are starting to learn how to manage these cases. Tomorrow I'll have another question, and then 2 other people can, of course, volunteer to do them. Okay. Do you have any questions for me before I go, other than telling me I need an Oscar for my acting skills? Even when you're working with other doctors, by the way, yeah, tell them to make it difficult. Tell them to give you a case like this. Like, what is this case? I'm here. You are the doctor. Assess patient James Smith. Go in and let them now give you the symptoms, as opposed to too much information. You don't need to be told to examine the patient. You don't need to be told to put in a Foley catheter. The question that I asked during the break about which are some of the, what was my question here? 4 differentials for acute. I think somebody's microphone is off. Let me just mute you, yeah? So here, what are 4 differentials for acute urinary retention? There you get your BPH, or urethritis is another one, injury, polycystic kidney disease, BPH, but I read them to you. So that if you're in a case where a patient is saying, I haven't peed for 10 hours, doctor, I'm in a lot of pain. We need to relieve this, we need to relieve your urinary symptoms. People come and say, I didn't see any Foley catheter, I didn't see any mannequin. Do you need to see these things? No. What if they're hiding them under the bed? So please be a doctor and think of these cases as real life scenarios. Let's see. I asked about IV fluids in MOC1 instead of the snacks. IV fluid dextrose. If a patient has hypoglycemia, your treatment has to be very specific. You just don't want to say IV fluid dextrose. You want to make sure that blood sugar, which is less than 4 millimolar, has to be managed with IV. By the time you call for the kitchen to bring orange juice and crackers, and they're confusing the rooms, they've gone to the ICU, you're in the emergency room, that patient's gonna die. So you want to put in a line, you want to start 20% of dextrose in 100 ml, or 10% of dextrose in 200 ml. Or you can say, I need to give this patient IM glucagon, okay? Constitution, 1 ml of sterile water. Okay, so you want to be specific with management. That way, even the nurse working with you doesn't have to think of ambiguity. And all this question asking, what do you want me to give? Give dextrose. How much do you want me to give? Give this. You're wasting time. Okay, so when it comes to management, be very, very specific. Okay, my dear friends, that concludes day 2. I'm really good at keeping time, I guess, for this review. So we'll see you tomorrow, yeah? I have other cases I need us to talk about. IV fluids, we're going to do that, and a few more other tricky ones. And then we'll have a mock afterwards. Have a good night. I'll see you soon.